This session's on disease-modifying drugs, DMARDs, biologics, and medication update. Now, this can be quite a big and turgid, boring subject, okay? So please interrupt me, okay? If I say something that prompts you to think that you need to ask a question, stick your hand up, because other people will have that query too, and otherwise we're all going to be put to sleep by my slides. So, I'm going to tell you something about inflammatory arthritis, just sort of in general terms, and then I'm going to tell you what DMARDs are. And in fact, just standing up here, some people asked me some questions about methotrexate and things, and I'm going to tell you what I think you need to know to sort of understand your medication. Because I think if you understand your medication and why you take different tablets at different times and why you inject things or take things by mouth, then you might actually understand why it has the effects on you, and you can learn perhaps to use the medication in a cleverer way to control your symptoms and reduce your side effects. Then I'm going to tell you what biologics are, and in both sessions I'm going to mention some of the things that have happened that are new. So, tissue damage in rheumatoid arthritis. So this is just an example on the left-hand side of someone with early inflammatory arthritis, and then on the right-hand side after a number of years of disease. Okay? Now, we get many people these days from the left-hand side, and we've got to prevent them getting to the right-hand side. Now, it wasn't that long ago, there's a professor of rheumatology, it was some sort of professor, Werner Wright, who said, clinicians may all too easily spend years writing "doing well" in the notes of a patient who has become progressively crippled before their eyes, okay? And so this is something about doctors needing to be ambitious for their patients, and patients needing to make sure their doctors are ambitious for them. Okay, it's very easy if I'm the doctor, I sit there and you come in and you say, "Oh, I'm okay," even though you're not. And then I say, "Okay, well, if you're okay, then bye then." It saves me. I always run behind, and if you want to save me time, that's brilliant, okay? But really, the whole point of that interaction is for you to tell your doctor what symptoms you have, and for your doctor to try and work out whether or not it's appropriate to try and improve them. So, let's just understand something about the disease. Now, this is a picture of a joint, and it's supposed to show the lining of the joint. There's the lining of the joint, and in inflammatory arthritis, the lining grows, okay? So the lining grows, and then the growth in the lining generates more fluid and swelling, and then this lining starts to eat its way through the cartilage and then eventually the bone in the joint. Okay, this is a picture of a bit of cartilage and some lining tissue, and you're supposed to see how you've got inflammatory cells chewing its way through your cartilage. Now, we actually do ultrasound these days, and we can tell this. Oh no. We can tell on ultrasound when you have quite thick cartilage. You can see there's bone, then there's a little black line, and then there's another line where there's a little bit of joint fluid that makes the thing appear bright. Okay. And then as you go through, you lose a bit of brightness, and then you lose a bit of the black stuff, and then the black stuff disappears completely, and then the joint is all irregular. Okay? So we can tell on ultrasound, and we're increasingly using ultrasound now during our consultations. So we've known now for at least 12 years that if, for instance, you get patients with rheumatoid arthritis, this was done in Leiden, and you say to them, okay, well, for some of you, we're going to start the treatment immediately, and then for the other half of you, we're going to wait 6 months and then treat you, okay? And then if you look at them 5 years later, you can see the ones that were started immediately without waiting for 6 months, their X-rays, okay, their X-rays haven't progressed. They haven't, well, they've got worse, but they haven't got as bad as the people who didn't start treatment immediately and delayed, okay? And the point is that that delay of 6 months at the beginning, these two lines never cross, okay? You never catch up, right? So that 6 month delay of initial treatment means that you will never quite be as good as you would have been if you'd started treatment straight away. So that's why we use something called disease-modifying anti-rheumatic drugs. Now, there's a whole load of them, okay? Sulfasalazine, methotrexate, leflunomide, hydroxychloroquine, azathioprine, mycophenolate, gold, D-penicillamine, okay? Now, I could go through a step-by-step sort of thing about how each one works. But in truth, we don't really know how they work, okay? Sulfasalazine, for instance, right? That was invented when people thought that arthritis was an infection with a bit of inflammation. So they got a sulfur-containing antibiotic and complexed it with salicylate, or a form of aspirin, and they created this molecule called sulfasalazine. Okay? Makes sense. You think it's an infection. You think it's due to inflammation. Just mix the two things together. Well, as it happens, the thing they've produced isn't a very good antibiotic, and it's not a very good anti-inflammatory. Okay? And initially, it didn't work. But in those days, they had nothing else. So they used it just at increasing doses, and they used it for longer. And they did actually find, by some freak accident, that it actually works, okay? Now, how does it work? Don't know, okay? We still, to this day, don't actually know how it works. It's one of the first designer drugs, because they designed it to work, and it wasn't very good. But when they eventually used it in high doses, it did work. And then methotrexate, lots of people are on methotrexate. And I was just hearing a question, someone came up to me, and they said they were taking 20 milligrams of oral methotrexate once per week, and then they waited 2 days, and then for the next 5 days, they took 1 dose of folic acid, okay? And they were getting nausea with the methotrexate, and they were thinking of dividing the dose on the day that they take it. So instead of taking them all in one go, they were going to take 4 at lunchtime and then 4 later on. Now, to be honest, feeling sick with methotrexate is probably related to the peak dose, okay? Methotrexate is rapidly metabolized by your body, okay? And probably within 24 to 48 hours, it's out of the body, okay? Now, there is no data, there is nothing to say in the literature that dividing the dose is any less effective than taking it all at once, okay? And so, in actual fact, I said to that person that go ahead, divide the dose, okay? And I'm hopeful that by dividing the dose, they'll get less of a peak dose and they'll feel less nauseous. Does that make sense? And so then the other thing is that if you feel nauseous 6 hours after taking the tablet, well then take it in the evening so that when you feel sick, you're asleep, okay? So there are just certain common sense things that you can do and introduce, okay? Because you understand a little bit about the medication. Go ahead.
she self-injects methotrexate, and she has a miprazole because they all make her feel sick. So can you self-inject? She self-inject the methotrexate. She self-injects once a week.
Okay, so that was the other thing. So the question is, I think, well, if methotrexate makes you sick, why not inject it? Okay. Well, in actual fact, you can inject it. Okay. Now, why should methotrexate taken by mouth make you feel sick? Why does anyone feel sick? Okay. Feeling sick is a very basic human response that enabled us to survive. Okay? If you ate something that wasn't quite right, you felt a bit sick, you threw it up. Okay? Now, it's a natural response of the body to be very careful about things that it eats, and if it thinks that you've poisoned yourself, you throw up. So methotrexate is a poison. Okay? So it's not surprising that when you take poison, you feel a bit sick. Okay? Now, if you inject it, the body hasn't spent centuries and millennia trying to bypass things you inject, because generally speaking, we didn't evolve ejecting things. So in actual fact, you find that when you inject the medication, it tends not to cause nausea. Now, one of the okay, sometimes it does. Okay, sometimes it does. Okay, but one of the other things to say is that sometimes methotrexate injected can be more effective than methotrexate taken by mouth. And so sometimes you can get away with a lower dose injected than you take by mouth. Why is that? Everything you eat, okay, goes into the bowel and then is absorbed and goes through the hepatic vein into the liver. And the liver tries to remove any poison, okay? And so if you take methotrexate by mouth, it goes into the bowel, is absorbed, and then hits the liver, and the liver does stuff to it, okay? Now, if you inject it into your skin, it goes all the way around the body. Well, it goes into the venous circulation, then goes into the heart, and then is spread all the way around the body before it gets to the liver, okay? Now, as I said, we don't really know how these things work, okay? The standard textbook answer for how methotrexate works is it impairs the action of the body's use of folic acid, okay? And that's why 2 days later we tell you to take the antidote, which is folic acid. Does it actually work like that? In truth, studies seem to find out that it doesn't quite work like that. It works through something else called cyclic AMP. But we don't really know how methotrexate works, and we don't really know where it works, okay? We don't know if the target organ is the liver, or if it's in the bone marrow, or if it's the white cells in the bloodstream. But if you inject it into your skin, it goes all the way around the body before it gets to the liver. So you might be able to get away with a lower dose, and you might get less nausea, okay? Shall I go back to the podium? Anyway, so hopefully people understand a bit more about methotrexate and how, oh, another question?
Thank you. Sorry to interrupt you on that bit, but on methotrexate, I actually take it because of primary angiitis of the central nervous system. Obviously completely different to rheumatoid arthritis, but I do have osteoarthritis. One thing that concerns me a little bit, and a lot of people seem to take methotrexate, it seems to be sort of flavour of the month, year, or whatever now. Many people that I speak to seem to take it, but I'm also aware of the dangers of it as well, that obviously being a layman, we don't know like the doctors know, but I understand that it can cause cancer, and I know one or two people that have actually got a cancer, been pretty much proven down to methotrexate. So my question is really, how long can you take it for? And is there a danger involved in it really, in taking it?
Okay, so there is evidence associating methotrexate, particularly with lymphoma. Okay, lymphoma is a form of blood cell cancer. Okay, now it just so happens that people with inflammatory arthritis are at a higher risk of lymphoma. So how do you separate out those people that getting lymphoma because of the methotrexate, and those that are on methotrexate because they've got another condition that predisposes them to lymphoma. And in fact, it's quite hard to separate out those things, okay? Now, there have been a few cases, and I'm aware of one of them, where in actual fact, a person developed lymphoma, they stopped their methotrexate, and the lymphoma went away, okay? So there is a small association possibly with lymphoma. People who have generally given these medications are already at a risk of lymphoma. We don't really know how much of the lymphoma risk is possibly related to methotrexate, but we are reasonably aware that if you allow inflammation to just keep going and you don't try and slow it down, then that does definitely increase your risk of lymphoma, as well as increase your risk of heart disease. And so there are other benefits of having good quality of life and good disease control, and generally speaking, we think the benefit outweighs the risks. You have to remember that methotrexate is also used as a treatment for cancer, okay? So people who develop lymphoma and other hematological cancers may well end up with methotrexate as a treatment for cancer, okay? So to say that so for instance, the other thing that someone asked me today about methotrexate and the lung, okay? Now, methotrexate has been possibly associated with lung fibrosis. People with inflammatory arthritis are more likely to get lung fibrosis, okay? But in fact, we do quite often treat lung fibrosis with methotrexate, okay? Now, methotrexate does expose people to a particular risk, which is something called methotrexate pneumonitis. So in that situation, people who are on methotrexate suddenly become breathless, they have a high temperature, they feel very unwell, and over a 2-week period they get very breathless and they start to cough, and then if you stop the methotrexate, it all goes away. So that's the reason why some of you may have been told when you were starting the methotrexate that if you suddenly get very breathless and you feel unwell, that you should probably stop it until you've talked to your doctor, okay? But generally speaking, people who develop methotrexate pneumonitis, okay, unless they have damaged lungs already, okay, if they stop their methotrexate, will do reasonably well. Does that make sense? It's only those individuals who have very bad lungs to begin with, okay, in whom if they have methotrexate pneumonitis, then they do badly. So which is why often when we start methotrexate, we get a chest x-ray. And sometimes we get a lung function test, so that we are making sure that we're not giving methotrexate to individuals who have bad lungs, who if they developed a side effect, would do significantly worse. Does that make sense? All right. So methotrexate, in terms of how long you can take it for, we have patients on it for decades, many, many decades. There's no real limit, I would say, as to how long you can take it. Some of the possible side effects in the liver, so the thing about all these things is, you know, everyone wants to talk about side effects, and you go away with this just remembering all these side effects that I've told you about. But in actual fact, there is an association with liver problems and methotrexate that is related to the longevity and the dose that you're on. That makes sense? So that's just an association, okay, that's in the literature, that people who've had liver problems have been on this dose for a length of time or whatever, okay? No one's really ever proven that, okay? And it just is a reason why you should try to take the correct dose of methotrexate that enables you to control your symptoms, but not you know, more than you need to, okay? So that's methotrexate. Does anyone want to talk about any of the other disease-modifying drugs on that left-hand side? Anyone want to ask any questions about leflunomide? Okay, leflunomide's interesting. It circulates between your bile into your bowel and then into your bile again, into your gallbladder, and then you eat something, goes into your bile, and then it goes around. And so if, for instance, you were to stop leflunomide, you actually have to sort of have a bile exchange, and we give you a little tablet called cholestyramine to bind up your bile to get rid of it if you need to. And so those are the old, on the left-hand side are the old these sort of usual disease-modifying drugs, there are newer DMARDs, okay? So one of them's called apremilast, okay? Apremilast, an anti-PDE4 inhibitor, is a type of anti-inflammatory, I suppose, and it's got a license for treatment of psoriatic arthritis. It can't be, it's not being used in rheumatoid, but it's being used in psoriatic arthritis, and that in fact is available now, as it were. It can be used. It's got a license. What we're waiting for is NICE to approve its use, and they haven't quite approved its use. Then there's another drug called tofacitinib, which is a Janus kinase inhibitor. I don't know if anyone knows who Janus was, but he's the Greek god of beginnings and endings, or something, some sort of a face that faces both directions. Anyway, Janus kinase is an enzyme used for the initiation of transcription of DNA within your cells, okay? And tofacitinib is approved in the United States for treatment of rheumatoid arthritis. Now, in fact, tofacitinib isn't such a great one, and in fact, it hasn't achieved approval in Europe, okay? So we can't give people tofacitinib. We do have one patient on it, but they were started on it in America, so we were allowed to continue it. But we can't give people tofacitinib. But there are other Janus kinase inhibitors being produced by different companies, and they seem to be much better, and they seem to be really quite good. But we just have to watch this space until they become available. The department is involved in some trials for some of the Janus kinase inhibitors, and some of you, if you meet criteria, would be invited to trial, I imagine. Now, the next bit I wanted to talk about was how we use disease-modifying drugs. So this is something called the Koba trial, okay? Now, the Koba trial compared combination treatment with sulfasalazine. Now, I don't know if people understand box plots, but really, in the shaded areas, the line to think about is the hard black line. And this is changes in X-ray damage, okay? Now, you can see that as the study went on, that the people that were just on sulfasalazine ended up with more damage than if they were on combination treatment with different sorts of combinations, okay? And this is one of the reasons why we tend to use disease-modifying drugs with each other. So we use methotrexate with hydroxychloroquine or methotrexate with sulfasalazine, okay? Because some of these trials show that combinations work better than treatments on their own. Now, there's another study called the BEST trial. Now, what the BEST trial, again, this showed that so basically, as the study went on, if you weren't responding, you changed your drug. So this is sequential monotherapy, so single disease-modifying treatments. And you can see that as you went on, by the time you got to the end of the study, lots of the people had changed, okay? Whereas if you compare it to, so if you compare it to people who started off with a combination, with a little bit of steroid, you find that people with a combination drug with a bit of steroid, okay, that fewer of them end up failing, and fewer of them need to move on to the next step. And if you start off straight away with an anti-TNF, even fewer of those move on, okay? So this graph is supposed to show, and I think this one shows it too, that if you try taking disease-modifying therapies either from the beginning with a biologic or in combination, okay, you find that you end up with, if you start off with the combination, you end up with better disease response, okay? So these crosses here, these are the people who started off with the biologic. And these ones here, these triangles, are the ones who started off with combination with steroids. So again, this shows that you more of them respond. So those people fulfilling the response criteria, these people did better than if you just took a single drug on its own, or if you took step-up combination without prednisolone. So this is just goes to show that if in an ideal world, if we were allowed to, we might give you biologics from the beginning. But in the real world, the combination treatment is what we try to do. And this is again shows that X-rays, that combination treatment with prednisolone and the TNFs had the lowest change in X-rays. So those graphs were supposed to show that we use disease-modifying therapies, we intend to use them together. And then there was this study called Tecora, and what Tecora was about was if we watch you closely, if we look at you carefully, and every time we get the opportunity, we see you every 3 months, okay, when you start off with your disease, and we try and make sure that we suppress your disease as quickly as possible, works better than if you just basically don't try and be too aggressive at the beginning, okay? So naturally, when people start their treatment, they think, oh, well, you know, maybe it takes a bit of time for this methotrexate to work. Why does the doctor want me to keep increasing the tablets? Why doesn't he just start me on 10 milligrams and see how I do? Why does he give me 10 milligrams, then 12.5 the next week, then 15 the next week, then 17.5? It's because giving it to people aggressively, getting control of the disease from the beginning, gives you a better outcome. That make sense? Okay, so biologics. So biologics, what are they? What's the immune system? And what's happening in the future? So what are biologics? Now, I think I went to town too much with these slides, so forgive me. Biologics are basically treatments that exploit our knowledge, I think, of the biology. And we have, for instance, been using biological agents in the treatments of various cancers. And I shouldn't really, this is something, we inject TB into bladders with bladder cancer, and we use interferon in viral hepatitis. Those are all examples of biologic treatments in other areas. Now, biologics are based on an understanding of how the immune system works, and in arthritis, it's really about targeting molecules that we know are involved in inflammation that damage joints. So it's just a matter of choosing our target and just shooting at it. Now, over the last 15 to 20 years, we understand the immune system so much better now than we used to, okay? And so we've got lots and lots of targets, okay? So this was an early study, an early example of what we understood about the immune system. This is from not that long ago, 20 years ago, okay? 20 years ago, this was an example of your immune system. A few little molecules, and TNF we thought was really important. Now, this is the current diagram, okay? It's now a lot more complicated. And if you look at the relationships between, if you try and look at the relationships between each of these little molecules we know they're all interrelated, okay? And this was just to show you how we know that TNF works here. We know that IL-17 works there as well. And we understand so much more about the immune system now than we did before, and we also know that it's much more complicated. I don't know if you remember, do you remember those people in London that were in a drug trial, and they were injected, and you know, they sort of got hospitalized, and some of them died? It's those sorts of, it was, you know, I don't know if people know, but it was basically people trialing these sort of drugs that you guys, you know, eventually end up with. But people were trying to find the next blockbuster, and in order to try and find it, they were doing these trials. And in many ways, you know, it's because these trials get tested, and they get tested in humans, there will always be first in human trials, right? That we end up with such amazing drugs that we have now. But I don't know if people, when they saw that heard those news stories, whether or not they really realised that it really had something to do with arthritis and our knowledge of the immune system. Because really, we are now, they're finding molecules, they're checking it in a few mice, and then they're trying it in humans. So whereas before they used to, the human studies are sort of going ahead of what we know about what these things do in animals, whereas before it used to be the other way around. So anyway, what do we have now? We used to have IL-1 treatments. Now we've got anti-TNF agents, and then we've got a whole load of other. In the future, we're now in the future basically, and we're getting a whole load of different agents that we can now use. Now, this is a bit of an old slide, and this was basically just to show that etanercept worked, and that although we did have some concerns about safety of biologic treatments in terms of TB, and some people worried about malignancies, but generally, really, the data's been reassuring. We do know that biologic therapies do increase the risk of TB, which is why when we put people on it, we screen people for previous exposure to TB. We know from our British registry that people with basal cell and squamous cell carcinomas of the skin occur more frequently in people on biologic treatment. So I don't know if people know what those cancers are, but they're the ones that don't spread, and you just find them and you chop them out, okay? They're not like the other skin cancers, which can be scary. They're the ones that are generally more easy to control, and they tend not to spread. So, we do know that some people, 30% maybe, don't respond to TNFs, and so the next drug along was rituximab, and rituximab works against anti-CD20 and targets B cells, and it works slightly differently to the TNFs in that each time you have a dose of rituximab, it removes a little slice of your immune system that you'll never ever get back again. But we have been using it successfully in rheumatoid arthritis for almost a decade now. And then we've now moved on to other biologic agents, tocilizumab, which is anti-IL-6. We've also got abatacept. And then on the horizon, we've got ustekinumab, which it has been a long-established treatment for psoriatic arthritis. Well, I say established. It's been used for a number of years for psoriasis, okay? And just in the last 12 months, or maybe a bit more than that, we've been using it for psoriatic arthritis since the government approved it. And then on the horizon, we've got secukinumab, which is also a treatment for psoriasis, and has got a license for psoriatic arthritis, and is hopefully going to be approved for ankylosing spondylitis by NICE. So there's lots of things happening. This is just an example of tocilizumab. People have been on the other biologics for some time, and this just shows how it can lead to responses of 20% improvement, 50% improvement, and 70% improvement in patients. This is an old slide, I'm afraid, because it's been around for some time. Now, because we understand so much more about these treatments, and because we are using our old medications more aggressively, we are trying to get rid of inflammatory disease. We are trying to induce remission, and hopefully that is a target that we intend to achieve for most of our patients with inflammatory arthritis. Now, NICE has been great, and NICE has been able to enable us to use most of these treatments and has been able to negotiate with the pharmaceutical companies to sort of say to them, if you don't drop the price, we won't let you use them. And so then they've had these patient access schemes which have allowed us to use it. But NICE have also stipulated that we should use the cheapest drug when we can, okay? Now, there are now, someone mentioned it in the audience to me before, there are now an increasing number of biosimilar drugs, okay? So these are drugs that are similar but not identical to existing biologic treatments. So there is, for instance, a number of biosimilar drugs to infliximab or Remicade, okay, that are called Inflectra and Remsima. Etanercept or Enbrel has now got a biosimilar, and that's called Benepali, okay? And these drugs come with different choices, okay? It means sometimes that people are obviously anxious about changing a drug, okay? They've been on Enbrel or Remicade, and it's been suited them fine. Why should they change, okay? Well, the NHS wants you to change over to the cheaper drugs because they're 30% or 40% cheaper, and they're quite expensive drugs. But we have been trying to work with the GPs to ensure that patients have a choice. And so we've said, we've had an agreement with our GPs that if the patient changes over but then wants to change back, we'll change them back, okay? But the other side of that is that there is sort of an expectation that people will agree to try to change to a biosimilar drug. Do people we've had a series of meetings on biosimilar drugs. Do people understand them, or do people have any questions or concerns about them? No questions or concerns. All right. So the arrival of biosimilar drugs in the market has made other companies try to change. So, for instance, you'll be aware that adalimumab have now got a different pen. Humira have now got a different pen with a finer needle, and it doesn't sting as much, okay? So interesting that they should suddenly develop that when there's this other competition that's come around that's a lot cheaper. It makes you prefer to stay with the one you've got if it doesn't hurt. So you can see that it's an interesting field, that we've got lots of treatments that we can now use, and that we are over the next few years going to see a whole series of drugs that say they're identical or very similar, and that where people might be asked to change over to them. Obviously, you're going to be anxious about it. Talk to your doctors and the nurses about it. We'll try and reassure you, and we'll try and ensure that you'll always have a choice. So, I hope I haven't bewildered you. I do think we've moved from an era where we were just pulling our hair out, trying to get people better but not really succeeding. We're now in the current state of affairs where we have increasing confidence in all the biologic treatments. We are getting more relaxed about side effects, but we do still look for them, and we are still monitoring for them. The number of biologic treatments that we can use has expanded enormously, and there are now even new oral drugs, the apremilast and the Janus kinase inhibitors. So maybe one day you might not even have to inject yourself. So in the future, Portsmouth Rheumatology will try and make sure that we get these options as quickly as we can by being involved in research, and we'll try and ensure that with helpful discussions with our GPs that we leave the choice for you to get the drugs that suit you best. Okay, question?